I am a nephrologist, and our group comes from a city in the north of Portugal, just on the other side from Oporto city. And as you know, monitoring and surveillance program for vascular accesses can increase patency rates and then reduces number and timing with a central line. International guidelines recommend us to have such a program. So, since 2011 in Portugal, there was a change in reimbursement plan in terms of vascular accesses. So, hemodialysis centers have the responsibility to manage their own vascular accesses. And new vascular accesses were created not only for declotted fistulas or grafts. We thought this was an opportunity to improve our own program of monitoring and surveillance in vascular access, particularly in fistulas, because as you will see, we have very few grafts in our clinic. So we defined that program and educate doctors, nurses, and include patients. Define who will going to make this, how, and when. Who are the nurses, are the centerpiece of this model. How they evaluate AVF on maturation and during cannulation time. In the first case, they do physical examination weekly. The fistulas that are in use, they do a daily monitoring. What they check: blood flow difficulties in cannulation, dynamic pressures, bleeding time, and they do monthly physical examination that I am going to explain how. They also measure static intra-access pressure related to blood pressure, and then, they measure also intra-access blood flow by a with transonic. This physical examination is very important in this program because nurses are trained to do it in less than 2 minutes in a quick, simple, and systematic way with these 7 steps of physical examination that they do. So, if the nurses find any abnormal finding in this process, they communicate nephrologists and they decide or not to refer patient to a vascular access clinic, and in that clinic they do evaluation with ultrasound of the vascular access. We have been published this model in our Portuguese of nephrology in the hypertension in the last year. After this, we made our registries and audit the results. The registries are made in this paperwork. So, the aim of our work was to analyze the results from our monitoring and surveillance program for fistulas, not grafts, implemented since April 2011. Patients with a follow-up less than 6 months were excluded, and endpoints were AVF thrombosis rate, catheters rate, and hospital admissions related to vascular access. We include 169 patients in this follow-up program, almost male, with a mean age 68 years, 1/3 had diabetes, and were on hemodialysis meantime 54 months. During the follow-up time, 35 months, we have 119 patients with a vascular access problem that went to that clinic, the vascular access clinic, where they detect 245 vascular access problems. I refer that 5% of the patients have at least 3 complications. The problems detected in that clinic were solved 1/3 by endovascular therapy, 1/3 by surgery, and 1/3 just surveillance. No other technique was necessary. With this program, we detect 13 thromboses, and these include 2 expected thromboses because the clinical conditions of the patients that allow us a thrombosis rate of 0.03 per patient per year at risk. 15 central lines were necessary, 12 temporarily until new vascular access were created, and 3 remain with the line because a nephrologist option or no other vascular options. These are our actual data on vascular accesses, and you see that we improve our results in terms of increasing number of AVFs and decrease significantly the numbers of CVCs with aligned CVCs. Sorry. And now, again, we only have 6.6% of patients with a catheter, and that rate includes prevalent and incident patients. So, our conclusion is that our program works. We have a success until now, and the principal message is the teamwork that we have to do with our nurses, nephrologists, and vascular surgeons. And here, the education has a very important central key in this process. Thank you very much.